welcome everyone to our second session, Global Panel. Super excited. I hope you enjoyed the first session. By all means, in the chat, drop a note where you're tuning in from. I hope this morning's first session gave you an insight into the sort of opportunities. And now I really want to bring in the practitioners, the people around the world that are actually making it happen, the pioneers, shall I say, on the ground, doing the work. Some fantastic examples here. Parkrun doing incredible work. I have to say, I take part with my daughter at the weekend, so it's something I have penciled into my diary every week. Libby, who's going to talk about compassionate communities. Robert, the work he's been doing from an academic perspective. Robert also kindly stepped in for me in Helsinki earlier this year, so I'm very grateful. Nick and I have been discussing London becoming a major hub for social prescribing, the walking tours that he's been doing. And Snigdha, who works very closely with me, an advisor to the G20 in India, and is leading the charge on WHIS India as well. So let's just start with a round of introductions. I'll hand over to, let's go with ladies first. Libby, over to yourself.
Thank you, and great to be here today. So my name is Libby Sallow. I'm Associate Professor of Palliative and End-of-Life Care at UCL, and my real research interest over the past 2 decades has been building compassionate communities, and that means basically understanding death, dying and grieving. They're universal events, they happen to everyone, but they're often treated in a medical way, through a medical lens. So this is reclaiming societal responsibility, community capacity and confidence for caring for people, supporting people through these times and into bereavement.
Super stuff. And Christina's joined us as well, but let's go across to Snigdha. Ladies first.
To be here and to be part of this very, very interesting panel. Looking forward to the discussions. A little bit of background. I have so my training is in public policy. I did my Master of Science from Carnegie Mellon University in Pennsylvania, the US. And then I was working in Washington, D.C. for almost a decade. And then I returned to India. And now I'm trying to do work on yoga and trying to bring yoga practices through government policies at a more larger scale. And that's where I've been very closely collaborating with WHIS and trying to represent WHIS in India, in fact. So looking forward to sharing all of those activities today.
Thanks. Go to Cristina.
Hello to all. Thank you very much for this invitation. It's a huge pleasure to be here. My name is Cristina Almeida, and I'm the president of Portuguese Society of Health Literacy. And thank you for the prize From Steps to Embraces. Is a program for elder people with cancer. And it's so good to be with you, Garrett, and all the team. Thank you.
Thanks, Cristina. Hussain in London, I think, or Leamington, I think.
Yeah. Well, Coventry to be exact. Hi, my name's Hussain. I'm a GP with an extended role in lifestyle medicine. I have the pleasure of being Parkrun's health partnerships lead, as well as working in roles at the Royal College of GPs as the lifestyle and physical activity lead, and working within medical and fitness professional education.
Fantastic. Nick.
Hi, I'm Nick Morissette. I speak in the capacity as Gareth said, as the London ambassador, but also from 2 very different contexts. The first as a CFO and head of compliance for a fintech, a digital bank. That's one role that I have. And the second one is as the rector of Holy Sepulchre, the National Musicians Church, the largest city church in the City of London, where we work directly with people experience isolation, loss, disconnection, the old and young, homed and homeless, well and unwell carer and cared for. And I think my big passion is that we have a city that is more generous and more caring and holds on to each other, metaphorically at least. Thank you.
Robert, over to yourself. And Robert, as you may as well kick us off as well and give us some framing from your perspective around social prescribing after you've done your intro.
Thanks, Gareth. Will do. So my name is Rob Dean. I'm over at the University of Lincoln in the UK. My official title, as it says there at the bottom, I'm an Associate Professor for Interdisciplinary Arts for Health. So very much involved in looking at social prescribing within the context of the role that the creative arts can play in that, from music to dance to art to sculpture to being in nature. All of those aspects of it are somewhere that I've really spent my time focusing. And a little bit more about what's going on at the University of Lincoln that I think is really exciting. We have a medical school there, so I also teach a module in social prescribing to medical students. I think that's a really important way of getting the word out there and getting advocacy, is actually having the new group of students that are studying medicine that will go on to be GPs, finding out about social prescribing and getting a feel for it, how it might fit within their practice moving forward. I've set a timer, so I'll move on to talking about the work that I've been doing, and I won't talk for more than 5 minutes, I promise, because there's lots to discuss, I think, in this wonderful panel that's been pulled together. I just finished quite a long research project in which I met with 40 people that had taken part in social prescribing in my region. These were all one-to-one meetings, hour-long interviews. We got to go really, really into depth. I've just published a paper, the findings of that, called Measuring the Iceberg. The findings in there that I'll just run briefly through, and our brief here was one insight from the region. The really huge thing that came from it was the hugely important role that link workers play within the social prescribing infrastructure. For those of you that aren't familiar with what a link worker is in its simplest form, a patient would go to their GP. The GP might recommend, have you heard of social prescribing? If that patient is interested, they would then be put in contact with a link worker who will then liaise with that patient in order to have a conversation with them, which often begins, what's important to you? So they find out what's important to the patient and then connect them with a particular social prescribing activity, and often go with them. The key finding there, though, really is that it's very, very rarely that simple. Many link workers will find that actually it's a lot more complicated than they were led to believe. Very, very rarely do they just go meet a patient that's interested in going to a book club and they put them in contact with a book club and it's job done. Actually, there's a lot of other things that need to be worked through. One of the huge findings, I think, from the patients that I spoke to was the point at which social prescribing comes into their healthcare journey is often very, very far along. They spoke of being frustrated with the healthcare system, frustrated with how they've been treated. So it very much, for most of the ones that I spoke to, it felt like a kind of last ditch attempt just to try something else. And it was often positioned that way to them by the GP as well. The GP that recommended it didn't so much recommend it as say, well, I give up, maybe try this. So it was interesting how it was being positioned. However, all of them spoke about the role, all the patients spoke about the role that the link worker played, always going above and beyond. And I've looked at what a link worker does in terms of what that job specification is supposed to be. The link workers go so much further than that. And I think it's really important that that is recognized, that training is provided, and even, you know, the amount that link workers are actually paid could possibly be increased to capture the work that they do. So that's finding number one. And then the last 2 minutes, I'll talk about what I think the research revealed in terms of both the challenge and the opportunity. The name of the paper, Measuring the Iceberg, what I was finding from the patients that I spoke to was that the aspects that they valued, the ways in which social prescribing had changed their life in so many ways. And I don't say that lightly. It's easy to sort of say in a glib way, it changed my life, but really the details that they were talking through in terms of not being able to leave the house before, suicidal ideation, all of these things, huge impact that social prescribing had. The way in which the impact of social prescribing is being measured, the metrics that are currently being used, barely scratch the surface in terms of what it is actually bringing to the people's lives that engage with it. So often the metrics that we're using, well-being score, the 4 questions that you do before and after an intervention, really don't capture the role that it's playing, and they do not tell the full story. It brings up the question for me is, who are we gathering this data for? What are we measuring it for? And time again, the organizations that I speak to that are gathering this data will say, well, this is what the funders need to hear. We need to which appeals to the NHS funders, the other places that we can get money from. We need to use their language in order to get investment. We know that it's barely touching the surface, really going on for patients. So I think with that challenge also comes an opportunity for us to look at how we bring these different kinds of data, these different kinds of metrics that we're gathering together to be able to evaluate and demonstrate the impact of social prescribing in a way that is actually accurate, that maybe even captures some of the ripple effects, not to the patient themselves, but beyond them as well. So for me, I think there's a huge opportunity there for us to work together to be able to say what we're currently doing is such a small part of the picture, but there are new ways and methods that we can start to capture the impact that this social prescribing is having on people's lives that really demonstrates that it has, both to the patients themselves, to their families, and to society as a whole. I think that's me.
Thanks, Rob. I think that's a fabulous insight. I think the ripple effect, and that's where I want to go to Dr. Hussain next, because I think when you talk about the ripple effect, there's one activity and it's sort of been pioneering this, and it'd be really interesting to understand how we can scale what Parkrun have done and how we replicate it. Now I know there's a couple of activities in Austria that are taking place with walking groups and other things, but Dr. Hussain's insight here into sort of run the data capture, the publications that they've had phenomenal success. So over to yourself.
Yeah, thank you. Yeah, as a health partnerships lead at Parkrun, I've had the privilege of working with governmental organizations, charities, local authorities, active partnerships in the UK and Wales, community groups. And so it's been great to learn and to utilize the expertise and skill set to understand, because I think what time has taught me in this role is that community is the intervention. Parkrun isn't a place, it's very much a people. And so we often focus on physical activity when we think about the benefits of Parkrun, but what makes Parkrun more powerful isn't simply that people move, it's that they move together. So Gareth asked me to look at one key insight, one challenge, and one opportunity. So let's start with the insight. And as I've stated, it's because community is the intervention, that's the insight. One of the most important lessons is that sustainable behavior change rarely happens in isolation. Many of the people we work with are living with long-term conditions, recovering from illness, maybe managing obesity, experiencing poor mental health, loneliness, social isolation. What we consistently hear is that they don't come back because someone told them to exercise was good for them. They came back because someone spoke to them. Maybe they felt welcome at the first timers briefing. Maybe that connection when they get the barcode scanned, that became part of something. At Parkrun, we're increasingly seeing that the social benefits can be the gateway to all the other health benefits. The physical activity that will improve their health, but it's belonging that improves that adherence. And there's kind of a special number in Parkrun. We know that if they can attend 3 times, that the chances of becoming regular park runners is massively higher. In fact, over 80% of those that will come for 3 times then continue to come regularly. And that's why I often say people may come for the activity, but they stay for the community. And it aligns closely with the direction of our new health and inclusion strategy, which is published on our website, which puts a really strong emphasis on people, partnerships, and places, recognizing Parkrun as a community health asset rather than a physical activity event. Now, the thing that works in practice, well, I guess it's in the UK in particular, building those partnerships around trusted relationships. Traditionally we thought about referral models, but what we've learned is that referrals alone are rarely enough. What works is when healthcare professionals, social prescribing link workers, community organizations, and volunteers, when they can work together to create supported pathways to participation, which are sometimes informal. So let's take, for example, the Parkrun Practice Initiative. This is a collaborative project with the Royal College of GPs in the UK. It also exists in Ireland and in Australia. This in the UK, it has over 2,200 GP practices signed up. That's over a third. And the most successful examples aren't those that simply display a poster in the waiting room, but it's where the teams get involved. It's where staff who talk proactively and positively about participation. It's where healthcare professionals who have attended themselves, or social prescribing link workers making personalized introductions or connecting them with that event. And the same principle applies across many sectors. You know, the strongest outcomes happen when organizations stop asking, and including Parkrun, we stop asking, how do we get people to Parkrun? And instead start thinking, how do we help people feel like they belong when they arrive? And that shift from kind of referral to relationship is where the magic happens, rather than just trying to focus on the numbers. Now, one challenge, our biggest challenge remains health inequalities. People who stand to gain the most from being active and being connected with the community face the greatest barriers. And barriers include low confidence to financial pressures, poor transport links, disabilities, caring responsibilities. The list goes on, and sadly, the list is very long. The health and inclusion strategy specifically recognizes that there's a need that we focus on underrepresented groups and reduce inequalities in participation. We've been doing this for years. It's not like we're just starting this now. And we have seen significant shifts and improvements in terms of understanding the people that are attending and signing up. So we are moving in the right direction, but work in this area needs to be constantly happening, because it won't ever be fixed. It's a constant battle that we need to challenge ourselves. And our opportunity, well, the opportunity is enormous. Across healthcare systems, we're increasingly talking about prevention. In the UK, in particular, neighborhood health. And all these agendas recognize an important aspect, that health is created in communities rather than in consultation rooms like my own. And I think Parkrun's uniquely positioned at that intersection because of the physical activity, the mental well-being, the social connection, the volunteering, which I think is probably the real gold dust of participation at Parkrun. And the opportunities for organizations across, whether it's health, physical activity, local government, to view things like Parkrun and other social prescribing interventions, not simply as kind of events that take place, but as part of the infrastructure of healthier communities, to create health within communities. And so kind of in closing, my key message is that community is the intervention. What works is partnership and belonging. And our challenge is ensuring that everyone feels that something like Parkrun is for them, because Parkrun isn't for everyone. Even though there's lots of ways you can participate, walking, jogging, volunteering, and it has a wide array of opportunities, I'll be totally honest with you, Parkrun is not the answer for everything. And in fact, there is such a great array of social prescribing opportunities slowly emerging. So how can we look to cultivate that and build that as time goes on? But ultimately, the goal isn't simply to get people to complete these events. It's to help people to find a place where they feel confident and they want to move, connect, and thrive.
Absolutely brilliant. And I would just encourage people just to go on to our website. You'll see the very first image is community, because that's what we delivered in Nottingham. And it can tell you the stories from the community that you're talking about is just phenomenal, the impact. And I remember last year being in Bologna, we launched in Italy, and speaking to colleagues there and saying that this we can apply around the world at a local level and get communities engaged. That's why I'm delighted, Snigdha, you're leading the charge in India. And yoga, again, fantastic opportunity to you to learn from what Parkrun's done, so you can bring that to a population of 1 billion people. I mean, so I'll hand over to you, Snigdha. Here you go.
Great. Thank you so much, Gareth. And it's so inspiring to hear about Parkrun. I think that's something I'd have to explore whenever I'm hopefully there next. So just to, as Gareth introduced, the work, one of the initiatives I'm working on at Peepal is to promote yoga, and one of the practices in yoga, pranayama, which is a breathing exercise that leads to the meditation practices, and how that is one of the ways for preventive mental health. So that's what I'm pushing for recognition in the Union Government Ministry of Health, of recognizing that pranayama and yoga can be considered an intervention for preventing mental health. And that, I feel, is very much aligned with the social prescribing movement that is looking at a more holistic need of a human being before you actually go to the medical intervention practice. So just to share more about the work I'm doing, I try to encourage people to look into yoga for mental health, in terms of anger issues, just loneliness. I run a hotline where you can just dial the number and talk to a yoga practitioner who will help you, guide you through breathing. And what I realized through this, this was more of an experimental intervention, but what I realized is that there's a lot of social stigma against acknowledging that I have depression or I am lonely. So we don't talk about it. We simply say, hey, here's yoga, here's something that you can do. Everybody in India, at least, everybody knows yoga, knows the practices at a social level, and of course there are similar traditional practices across the world. So I'm trying to leverage that and not talk about depression or anything that there's a social people would not admit to, but they would be keen to do these practices. And then, of course, the economics of it, because there are not as many trained psychiatrists or psychologists, at least not in India, and I'm certain not as many as we need globally. So in terms of access to trained yoga practitioners, there's a huge pool. There's an opportunity for job creation for them. And of course, the fact that you could, at a very low resource interventions, you could address some of these problems of loneliness or mental calmness that we see every day. So that was the experiment we did with the Ministry of Health. And that's again what Gareth was saying, that if you have to reach 1 billion people, you have to partner with government institutions. You have to partner with a large institution. For example, I am right now working with one of the voluntary social institutions, which is very famous for yoga. So trying to collaborate with them, because and it's a voluntary organization, but it's pan-India and we're running for decades. So collaborating with them, collaborating with the government institution, collaborating with multilaterals, and of course international organizations is hugely important to be able to impact at scale. So that's something I'm working on, and technology. I mean, the penetration of technology in Indian villages is fascinating. They may not know the basics that you would expect, but if you tell them to download and to make an online payment through UPI, they will do it in 10 seconds. So it's fascinating how technologically literate everybody is. So that's something we are hoping to leverage. So these are the ways we're trying to leverage to scale low cost, light touch interventions for preventive mental health through yoga pranayama. Yoga pranayama can be replaced by traditional practices of any culture, but we've picked up yoga and pranayama because that's what is familiar in India. So happy to share more over the course of discussions.
Thanks a million, Snigdha. Fabulous insights, and I think there's so many lessons to be learned from Rob's experience in paper, and then also leading into Parkrun and what they've been doing with their interventions. And it certainly is all about the community, and you can create this enormous community around yoga. Now I'm pretty keen to get a bit of an insight into compassionate communities from Libby. We met a couple of weeks ago, and James just spoke about palliative care. This is a really exciting piece of work, and you can check out actually the State of Social Prescribing report. Libby's contributed quite a considerable piece to it. Libby, over to yourself in London.
Thank you. Thank you, Gareth, and great for James to be introducing palliative care and end-of-life care in as well. So thank you so much for kind of putting that front and centre, because I think one of the big challenges with caring for people at the end of life, whilst they're caring, while caregivers themselves to bereavement, is it's often kind of hidden. That's one of the big challenges. It's hidden away. These are difficult issues to talk about. These aren't kind of the ones that are immediately ones that people want to engage with. They're tough, and loss is hard. But I think the biggest opportunity, both as its biggest challenge, is that these are universal events. These are events that every person will be affected by, will experience either as a carer, through bereavement, or as their own end-of-life care. So that kind of gives us a big mandate. Like, these are essential. These are not rare events that will happen to some people, that will happen to everyone. But the challenge is that they're distressing to talk about, and understanding and imagining people we love not being here and us caring for them means that people don't want to engage in it. which then means often you kind of become a carer or experiencing end of life issues without much support, leading thought, kind of narratives, support around you to how to manage that. And whilst we've been pushing for lots of good clinical care, that's kind of become the main lens that we see this through. End of life care is often seen just you need good clinical care, doctors, nurses, other support around you. So the Compassionate Communities Initiative that's been going for 15, nearly 20 years now is looking at taking ownership back to the community, understanding that death, dying, caregiving and grieving are not medical problems, social issues, they're social experiences. And so whilst you need pain relief and good doctors and nurses to support part of it, the much bigger part of that is a social response. And things like social isolation, caregiver distress, support, suffering around that don't just need more tablets, they need a community response to that. The Compassionate Communities aim to build that and kind of take that ownership and agency back from clinical responses into the community. So these are examples that have been set up all over the world. We did a big study last summer, we're just writing up at the moment. So rather than the kind of 15 or so initiatives globally that we're in the published literature, we know there's a huge hurdle for how grassroots initiatives can actually publish evaluations in peer-reviewed journals. So we did a big survey that was out to the QR code, anyone could reply. We did a huge global reach out. We found that 326 different compassionate community grassroots initiatives working to support people caring, people experiencing life-limiting illness or people grieving across all WHO regions, across all different income levels, across all different levels of palliative care, service delivery, development. So these now are everywhere, they're across all different jurisdictions. And crucially, what we learned from that study is that they are doing huge amounts of work, awareness raising, hands-on support of people who are caring, support for people who've got young children going into bereavement, and building community capacity to respond to these issues. And crucially, they're adding something more. Clinical services can't do this. It isn't that there's not enough doctors and nurses doing X, Y, Z. It's actually these need to be dealt within the fabric of society, where people experience serious illness, it's where people experience caregiving, often where people want to be at the end of life and then when they're dying, and it's certainly where people experience bereavement. So that's where the resources and support needs to be. And the good thing about the social prescribing, I think it's been mentioned some of the other speakers today, is that you get benefits on both sides. If you decide to become a volunteer and be part of a compassionate communities network where you're supporting people who live amongst you with these issues, then you get benefits, and we've seen the benefits that come from that. If you're someone who's isolated or caring or experiencing end of life, and you're then supported by people around you, then you get benefits from that angle as well. So it works in a reciprocal way. And as I said, these are universal events. So this isn't about certain people giving support to others who, in something they'll never experience. We will all experience this. It's just that people at different points of that life course. So a real sense of actually doing this because I need this at some point for me. And so it's a kind of circularity and a reciprocity that is really gratifying because it's part of our human condition. So there's a real kind of impetus getting that good support. To be an absolute universal foundation. That's my vision with this work. This is the universal foundation on which excellent clinical care, excellent spiritual care, etc. sits on. There's a community capacity that's this strong basis. And the exciting thing is we can see it's growing. The last, I'm always a glass full, I think, optimist about how we can make this work. These are, not straightforward. Obviously, there's difficult issues. But what we've seen is since 2010, the data shows there's a huge uptick in a huge number of new initiatives started. So it's a growing movement, there's energy, people are wanting to take part in this. And although these are sad and, often really difficult issues to really deal with, not dealing with them makes it even worse and even harder. So I'm really excited to see just this energy and growth in this area, and I think that's our biggest challenge, how tricky these issues are, but the biggest opportunities people are ready to grapple with them. So it's really exciting.
Thanks, Libby. Fantastic insight. I'm looking forward to it. We're going to be coming back around for challenges just after we do our first round of discussion here. So let me hand over to Cristina, who's in Portugal. Cristina.
I think my sound is
yeah, you're back on.
Okay, thank you. Thank you for this opportunity, Garrett. I would like to bring 2 or 3 ideas. First, that we live in a fragment world, and social prescribing comes to connecting people, to break this fragment world. Second, disease must be a reason to include people and not to exclude. and to empower people. So sometimes we think that, okay, disease, people can get to home, don't do nothing, but disease is a reason to include people. And third, we need organization and networking to implement social prescribing. And we as researchers, we live buried in metrics, in systematic reviews, and with data. But data must not be in a shelf. So we must use data to bridge a better quality of life. And when we say quality of life, we must implement with organization. And organization is doing networking. In Portugal, Portuguese Society of Health Literacy, we have more than 100 partnerships, because without partnerships, we cannot build a good network for social prescribing to look to the people. And in this network, we must include municipalities, schools, we must health organizations, social organizations, academic hearts, as Rob told us. And we must choose some good practices that the groups have. And that's why we built the program from Steps to Embrace, physical activity for elder people with cancer. Because we know that elder people with cancer must do exercise. But not they must do exercise participating in their lives, not only do exercise just for have a good body. So we intend with the academic, with the partnership with the municipalities, with hospitals, and the idea came from an oncologist, and then we organized this huge network that is in, from Steps to Embrace is in the National Plan of Longevity, and we have a group that twice a week, more than 50 persons do exercise, and they find that is not exercise, is to change lives, is to rebuild confidence, is to rebuild autonomy. And we must organize a previous strategy to social prescribing, not just making heart because it's good or making physical activity because it's good. We must do things that people want for their lives, to be significant for their lives. And this means that we must be well organized as entities to share our skills to these people and to connect this networking. And we organize in the Portuguese Society of Health Literacy a lot of social prescribing activities. For example, the round of tales for children. We know that reading loud, improves the neural activity of these children and for the parents. So we must work together to achieve better results. And that's why I'm very grateful to work with Garrett Presh and WHIS, because we know we are stronger now that we started in 2022 or 23, I can't remember, it was a very good line. And the other thing that we must profit very good practices that other partners have. I heard here from Al-Zubaidi and for Lily and Robert, good practices that we must cross these good practices around Europe. And we are in a good shape in social prescribing. We must increase the level of partnerships, and also a point that is for me very crucial, this sustainability. If we are not there, how this can continue? And sustainability means also financial grants, supporting financial for these activities, because we are researchers, we are technicians, we are medical doctors, but in social prescribing we must be organized and we must have funds to build a better community. And that's why I believe truly believe that this could be a very changing of this fragmented world that we are living now, and to combat, as Lily says and the other partners, loneliness, addictions, previous mortalities. So this is a very good way to change lives. Thank you.
Thanks, Cristina. Yeah, it's been a fabulous journey the last couple of years working together. We really covered a lot of ground. We launched activities a couple of years ago working together, but you're absolutely right. It's a paradigm shift. We also have to bring the financial means behind this movement. And that's basically what the Social Prescribing Alliance was set up to do, was to bring the financial means, but it's very much built on trust, transparency. If you're going to bring together such a wide community, you have to base that on trust and transparency. And the same applies to when you're dealing with financial institutions. You have to work with honesty and integrity. And then this leads us on to Nick, where I think, Nick, you can give some fantastic insights into the discussions we've been having around the hub in London that we're building out, how we make it sustainable, because we've had the discussions with yourself and Matt, and we're super excited to build out this framework, particularly from London's perspective, because you're a financial capital, you're a financial hub, and we are engaging with those banks.
Here in the heart of the city of London, in Holy Sepulchre, Grade 1 listed church, it's the largest city church. We've co-developed a family of creative health and community activities whose name all ends in T. And there are 5 so far. We have musicality, tea, tales and tunes. We have community, sing-along skills, socialize and sharing. We have creativity, walks and wonders, parks and places. We have humanity, honoring heroes past and present. And we have militarity, which is about sustenance songs and service stories. And that word T at the end isn't incidental. It's about signaling welcome, informality, hospitality, and equality, where people are not received as patients or unwell or well, service users or beneficiaries or anything. They are received as guests and new neighbors, and we are hosts. Hugely important to us. They are distinctive, not discrete communities, each of them. And this program of co-developed, co-created activities are dementia friendly. They involve music and community arts, movement, creative activities, veterans heritage, storytelling, intergenerational oral history, and well-being journeys through the city's cities areas. And maybe before I just give a particular example, I mean, there are 3 perhaps emerging particular points around these activities which are important. First is that it's dignity before any diagnosis and before actually any judgment of why somebody has found us or been referred to us. The people may be experiencing loneliness, bereavement, declining confidence or mental health, or they may think that that's coming down the route for them. But they also arrive with experience, abilities, memories. And so recognizing and seeing that whole person is important to us. The second is that we see multiple routes into these co-created, co-participative activities, of which one of them is clinical, but often what we find is those recommendations from carer groups to us, we end up having the carer and the cared for coming in. The husband with dementia, the wife who's looking after them. Who has the priority of preventative health from a community? And then the third element is that we see this as from when that arrival happens as a progression from receiving and welcoming to that person contributing, if that fits their journey. And so we see this isolation to participation, from participation to contribution, from contribution to belonging. And this journey that we take people on is a key part of what we believe is possible without pushing the pace. I just want to give a particular example of one of the things that we've just launched, one of those 5, which is our well-being journey program. Each of the journeys that has 2 pathways with connecting bridges, and I apologize to the non-clinicians here, it's a double helix approach with one heritage pathway, helping people to notice history, character, and the change around them, of the physical changes in the city, and a well-being pathway using the places and stories and observations to prompt reflection, conservation and connection. You know, a building adapting over centuries can lead to reflection on changes in our lives or lack of changes in our lives. A memorial of an apparently ordinary act of courage may prompt something quite actual reflection of those who've served us in our lives or how we can serve others. A garden within the city may create a space to notice what we've been overlooking in our life. And these journeys have been created in a way so that they can be experienced in a number of ways. They can be experienced as a guided walk, which we've piloted. This double helix is critically important. They can be experienced as a self-guided physical journey. They can be experienced as a seated digital experience from your office, from your desk, from a community space or your home. And that aspect of inclusivity isn't just about physical inclusivity. It's about removing all the barriers to joining in with it. It's about creating different ways for people to participate according to their mobility, according to their confidence, their circumstances, and that immediate preference at that moment in time to be able to say, I can do this and I want to do this. How's that going?
There, Nick, a little bit of feedback. I'm not sure. That's it. Yeah, brilliant insights, and also I really love the holistic approach, and being able to embrace all parts of our communities, which is just wonderful to see. I just want to go back to Rob now. Rob's had you've had an interesting insight into the fabulous examples of the global work that's going on, and perhaps you could give us an insight into the sort of challenges you see we face. And I'm going to put this to all of us, to everyone on the panel here.
The challenges. The challenges that we face. From a research perspective, I was on a wonderful panel. This would be 18 months ago now. And someone was in the audience, and they asked the question, which kind of threw me. And because I was a researcher, they said, at what point have we got enough research to just accept that this stuff works? And they use the phrase, just pull the lever on it, and everyone can go, yeah, we've proved it, it works. Let's just roll it out, fund it, and make sure everyone has access to it. And I didn't know what to answer to that question. Because I think it's a really fair one, and I think for me the challenge is, in amongst all the other challenges that I've talked about, particularly around evaluation and the way in which we demonstrate its worth, is for us to move beyond defending its position and trying to kind of say and advocate for it and to convince people to kind of win the hearts and minds of funders and patients and doctors and all those things, to actually get to a point where we can go, we've demonstrated it, it works. Now can we really start to bed this in the same way that we don't have to we don't have to prove that giving up smoking is good for you. We don't have to prove anymore that going for a run is good for you. But I think that we're still kind of stuck in this kind of hamster wheel of having to prove our worth, having to prove what money will save, having to demonstrate all of these things. And in so many ways, it's really, really clear and apparent. And then the last thing I'll say, as I've thought about it, one of the things I often think about with social prescribing, I imagine if my grandmother was still alive and I had to explain to her what social prescribing was, and I talked through it, I would imagine that she would say, isn't that what you have within the community anyway? Doesn't it just exist in the community? And I think the global picture that I've got as I've traveled around is that that's actually been really, really stripped away, particularly in the kind of Western countries that I've spoken to, that community has really, really been hollowed out. And then the very last thing, so I'm thinking about it now, is something that I mentioned to you, Gareth, when we spoke earlier, and something I think that's really come out from the travel. So I've been lucky enough to get funding to travel around the world and speak to people about social prescribing. is being really wary, particularly from a UK perspective, that what we don't do is a kind of colonial version of social prescribing and say, in the UK, we do this, this is how it works. Actually, there is so much to learn from other countries, from other communities, particularly the amount that I learned from indigenous communities within Canada, for instance, where maybe that idea of community and that crossover between that personal health and that medical version has actually not been lost in the same way in which it has in the UK and I think other Western countries. So really being open to learn from other cultures and communities about how this can be done in a really effective way.
Yeah, couldn't agree more. I think you made such an important point when we spoke as well, and I'm actually in discussions with a number of GCC countries at the moment, and actually that was the point I was making within the sort of technical brief that we were writing, was to say, look, this has to be done at a local level. A point you make, and I'll put this to Dr. Hussain now. One of the things I spent many years in the Department of Health in Ireland, and was an advisor to the Minister for Health around haemophilia. And I think I learned quite a lot over the last couple of years. I realized when I was in the policy division and writing these sort of public policies and representing the Department of Health or the statutory agency that I was managing, I always had this mindset that I was there to protect the state, and that I was sort of to push everything sort of away, shall we say, and make sure that. But I think the lesson here for anyone who's tuning in from a policy perspective is very much to look at how you can create value for the state, and sort of how you enable things to change. And what we're demonstrating here within the policy sector is that this works, and it really does work. And you should be enabling this to happen and pushing this forward, and working collectively, because then you can release the financing, because the financing is actually there. So Dr. Hussain, from your perspective, I know you're doing so much work from a research perspective around Parkrun, and it works so, but the challenges, please let us know.
Yeah, absolutely. I think the evidence to suggest that being active, being outdoors, being community works to improve health is obviously already there. I think where the evidence needs to build, and where we've been building that evidence through discussions with DCMS, that's the Department of Culture, Sport and Media, is trying to understand, do we have effective mechanisms to support social prescribing in underserved communities? Are we able to use initiatives like, for example, Parkrun Practice, which, for those of you that don't know, this is, as I said before, that collaboration with the Royal College of GPs, looking to signpost patients, refer patients to the local Parkrun event to either volunteer, walk or jog. Does things like that, does that have an impact? Now, I can't disclose the specific numbers because it's due to be published very soon. But what was clear to see in the evidence that we've done is that, yes, it does have impact. And there's a lot more potential for how it can have greater impact in increasing attendance. And we've had further evaluations to try to understand, what is the engagement when it comes to these kind of initiatives, as well as what is the impact on the quality measures at let's say a primary care center. Does it improve the patient satisfaction? Does it improve the quality outcome framework? So these are the measures that they are assessed against for potential additional funding, etc. And that has been published and done by Dr. Callum Leese and his team at University of Dundee. And that showed across all three areas, whether it was patient satisfaction, CQC rating, which is the Care Quality Commission rating, and those quality outcome frameworks, we saw improvements for practices that took on the Parkrun Practice Initiative. And of course, that's an association. And so you may very much question and say, well, good practices will take on these additional initiatives. And that's very much the case. But what we now have to shift is how can we support other practices that may be not feeling prepared already to take on initiatives like this and engage in social prescribing? What is it that we need? What do we need to shift in the terms of the environment of their work and what they do to get that across? And so I do think there is further research required in those areas to answer them, to make sure that, yes, we know that getting them there will help, but how do you do that? What is the actual implementation required? What is the training needed to upskill the staff, etc.? I think there are still questions, because at the moment, even in the UK, where social prescribing has been getting more and more traction over years, some brilliant work happening. There's still it's scratched the surface. It very much just scratched the surface as to utilizing it as a potential tool.
Definitely. And I think you're right. We are only scratching the surface. Like really, 80% of the social determinants of health is outside the medical system. But yes, we have billions of pounds in the UK, if you just say UK context, are focused on that 20%. So we literally are just scratching the surface. When James mentioned earlier, the 350 million for the 3,500 link workers, that's out of a budget of over 200 billion annually. I mean, this is really only scratching the surface, but that then shows you the opportunity that we have. Snigdha, from your perspective in India, this must be music to your ears, because you actually have an opportunity here to leapfrog what the UK has done and learn, and not put in that heavy, intensive, shall we say, hospital-centric system. And you have a bigger population as well, so it's a far bigger opportunity in my idea. Go ahead.
Great, thanks, Gareth. And yeah, it's great to hear, especially what Dr. Dean was saying about the perspective from Canada and how they are valuing their indigenous knowledge and imbibing that into the medical practices. And that's, it'll be amazing to see more of those cases and that becoming more mainstream across the world. And it brought me back to a discussion as I was having an informal discussion I was having with the former very senior secretary to Government of India. And I was telling him about this work I'm trying to do, and he said, first thing he said that well, I don't think today you need to prove to anybody that meditation is good for health. 20 years ago, you probably had to fight and publish up and create evidence for it. But today, nobody can argue this, and that's true actually. At least in some of the countries, I could definitely say that if we go and say that, hey, meditation and breathing and whichever word they want to use is good for your holistic well-being, there's probably not going to be a lot of debate on that. The challenge, however, continues to be is on practice. People may know it, but how to implement it, how to make it become part of the daily routine, and that's something that we're working on, and that I think is where globally we are in terms of the challenge that we're facing. How do we bring it as part of the medical system? How do we make it more acceptable as well, to use the parlance, intervention in the medical systems and hospitals? That should there be a meditation room, or should there be a practice for meditation for patients? That sounds like a dream today, but it's great. I'm happy to share that the Government of India has created an entire dedicated ministry for yoga and Ayurvedic practices in India. So with that and the Ministry of Health working hand in hand, maybe in a few years we'll have more. You'll come to an Indian in India, and you'll probably see a lot of medical meditation practices, yoga practices being accepted mainstream. But right now, of course, there's a huge battle, turf wars happening. But hopefully we can swim through and find something that is aligned with the whole social prescribing philosophy.
Thanks. And let's bring in Libby quickly. I'm conscious of time as well. So we've got like about 6 minutes, and I want to be able to bring everyone in for a final word as well. So Libby, challenges from your perspective.
Thank you, Gareth. So picking up on some of the things that all the other speakers have said, I think one of the big challenges is legitimacy. So both for communities feeling that they have a role and a right to take responsibility and have action in this and take care of people who are living amongst them, and that they have something valuable to contribute. And so it's kind of getting people over that hurdle to understand, yes, you have a right, and this is part of your human role really, to take care of people who are near you and who need support. And the other side is the legitimacy within the clinical health kind of professional health services side, which we've spoken a lot about. And obviously research is a tool for kind of leveraging that kind of power and saying this is valuable, but it's that implicit belief that there is more to building health than healthcare services. And Gareth, you've alluded to that. We know it's the minority, but somehow that message is not getting through into healthcare. So how, I'm a palliative care doctor, I'm going out seeing patients this afternoon, and one of the key things I want to look at is look at people's social network, look at the kind of context, the conditions in which they're being cared for, or they're living and dying, because that has the biggest responsibility, that has the biggest effect. But that message is not getting through. So it's both legitimacy for communities to understand they have a right, and I'd say a responsibility to be in this space, and the same from healthcare professionals and wider social care professionals to understand that there's something that's added, that's brought so much more than just the medical and kind of clinical medication or whatever clinical interventions are done. So it's that kind of dual legitimacy. And to pick up finally on Rob's point around the grandmother test, I like that idea of what would, if you presented to this kind of idea to your grandmother around compassionate communities, I think grandmothers globally would say, well, this is surely part of the fabric of society. This is just what, being a good neighbour, being a good friend, being a good family member is. So this isn't radical, and not that we're romanticising how things were before, obviously, but the idea is that actually this is part of being a connected society.
Agreed. Always listen to your grandmother. Cristina, over to you. Some of the challenges. I think
to increase the level of trust and confidence of the people, making the participation of these millions of people that go to social prescribing. So communication is quite important, but the communication from the public is quite and huge important to create this awareness, this global awareness. Sometimes we see some photos from groups or from people doing this and hearts and gardening and blue zones, but we need to put the voice of the beneficiaries inside the social prescribing highlights. And we have also another thing that is the opportunities. Sometimes we don't know, I saw that in municipalities, sometimes they want that people want to do gym or gardening or swimming pool, but if there is no swimming pool, people won't do physical activity in water. So all partners must be awareness which opportunities they have inside the communities. It's like think global but act local. And communication is quite a huge and important way to disseminate these good things. As the basis of health literacy, we develop competencies to generate motivation. But to generate motivation, we must communicate with people and give voice to the people. So we have, for example, mini assemblies of health that we aggregate people to give voice to the communities, and this works very well. So my challenge is to increase this level of communication from the public, from the beneficiaries.
Thanks, Cristina. Giving communities a voice. Nick, over to you. Nice and quick challenges. Sure. I want to try and give everyone a final word really quickly as well.
Mine will be very quick then. Overall, I think there's as you already said, there's a key aspect of funding these community-based pathways, full stop. But I think underneath that, I'll just suggest two sort of root causes that are, I think, a problem. I think there is individual and institutional egos that need to be sorted out. Lived experiences and academic experiences and research, we have to lift up the evidence of lived experience and actually equalize it to recognize that it has some weight. And I think secondly, we've got to build a culture of belief that boldness and community cohesion is possible. And I think that is part of the challenge. And actually that is what's creating, to a degree, a hopelessness and a lack of potential. And if we can change that culture, and I think we do that through just doing it at times, getting out of our seats, joining in, and let's just show the world that it's possible.
Okay, let's show everyone it's possible. We've got just less than a minute for everyone to go through quick final words. Rob, over to you quickly. Last thoughts.
Just more events like this, more opportunities for us to talk to each other, and to connect. I think that's
brilliant. Dr. Hussain.
Quite simply, community is the intervention, and that's what we have to focus on always.
Thank you. Snigdha.
I do agree. I think behavior change is just accepting that social prescribing is a serious and an important part of the entire intervention process is I think, the key. So I would focus on behavior change, and I do agree with having more such events and funding and all of those things, definitely.
Libby.
It's already happening. We've got examples around the world. We don't need to reinvent this. We just need to share it and catalyze it.
Love it. Cristina.
Partnership and this kind of events are very good.
Thank you. Nick.
Set up a league table. Who is the first city in the world that says we will be the global leader as a dignity first city where no one is left behind?
Love it. Absolutely love it. So there's the challenge. Nick set a challenge for us. Municipalities listen, reach out and get in touch. I'm going to close this session. We're just on the hour. Join us in 15 minutes. We'll have a fireside chat with Nikki and with Peter. This is going to be about kindness and leadership. Don't miss it. So we'll see you online in 15 minutes. Thanks, everyone. And
thank you.
Been a wonderful session.
Thank you.